All right, folks, we're going to go ahead and get started. I'd like to welcome you for joining us. My name is Mandy Lyon, and I'm serving as this year's president of the Parents Association. I'd like to welcome you to COVID-19 Conversations, our third SCHConnex event. SCHConnex is a series of virtual experiences designed to connect you to new ideas and each other. It's sponsored by the Alumni and Parents Association, as well as the SCH Fund. Tonight's event will be moderated by SCH Medical Director and Pediatrician, Dr. Heather Lubell. And Dr. Lubell is a fellow parent of a 2018 graduate and a 2022 student here at SCH. At the end of the presentation, we will be taking questions through the Q&A tab, and we'll answer them as best we can. Dr. Lubell.
Thank you, Mandy. Thanks to the SCH community. Welcome. It's a pleasure tonight to be moderating this conversation about all things COVID. We are joined tonight by Dr. Russel Kaufman and Dr. Charlene Bierl. Dr. Kaufman's an emeritus professor at Duke University in Medicine. He's the president emeritus at the West Heart Institute, and he's a hematologist oncologist with an expert in vaccines. So thank you for being with us. Dr. Bierl is also a parent, class of 2026. She is currently the director of laboratory medicine at the Hospital of the University of Pennsylvania. She's an associate professor in the Department of Pathology and Lab Medicine at Penn, as well as a clinical pathologist with 15 years of expertise in the area of clinical testing. So, Dr. Kaufman, why don't we get started?
Thank you, Heather. First of all, there'll be three physicians that are talking to you tonight, but what we will provide for you is general information. It's not specific information. You wouldn't want to ever act on any of this, on your own. You would consult your own healthcare provider before you did that. But we hope this informs you and also makes you more comfortable and helps you understand what we're going through right now. Also, it'll help protect you and your family from this pandemic. This obviously is a serious condition. And just for terminology's sake, the virus that's causing this pandemic is called the SARS-CoV-2 virus. It's a coronavirus. And the disease that it causes is called COVID-19. So when we talk about those two, we're either talking about the virus or we're talking about the disease. And obviously this is a very serious condition because worldwide there have been, as of last night, over 37 million people have been infected and over 1 million people have died of COVID-19. And in the United States, almost 8 million people have been infected, and we have over 219,000 deaths that are attributed to COVID-19. So obviously this is a very serious condition. And the next slide is going to just help you understand that on the left is a virus, and that's different than going viral. But sometimes I think maybe TikTok is a pandemic, worldwide pandemic, but in a different form. But you can see the virus on the left, and the virus is not a living organism, but it's capable of entering a cell and taking over the machinery of that cell. And its main goal in life is to make more viruses. So it's got a pretty simple purpose. And the little red spikes that you see there, they're called the COVID spikes. And those will be important as we talk later on about vaccines and about diagnosis even. So the next slide really helps us understand why this pandemic is so different than other pandemics. In fact, many of you have probably gotten pandemic complacency over the last 20 years. 20 years ago in 2003, you heard about a pandemic called SARS, and that was the first one. That was a cousin of this particular virus. It too was a coronavirus. And worldwide though, we only had about a little over 8,000 people were infected by it, And in the United States, only 8 people were infected. So you say, why is this a pandemic? Well, it did spread all over the world, but it had a very particular characteristic, and I'll cover that in just a minute. But then there are these other pandemics, SARS, Ebola, H1N1, Zika. Well, you heard all of the dread things that were going to happen, but for people in the United States, it didn't happen. So we had a sense of complacency when we heard about this particular virus. But why is it that this virus has caused so much disease? Well, one, it spread through the air. Now, SARS, the original SARS virus, was also a respiratory virus. It spread through the air. But this virus, only a tiny dose of virus is necessary to infect you or to cause disease. And there's an ironic thing about this virus. It's actually almost diabolical, I would say, is that this SARS, this CoV-2 virus is less lethal than the one in 2003. So you would say, well, wait a minute, if it's less lethal, why is this one so bad? Well, it has to do with 2 features of viral infection. One is called the incubation period. And the incubation period is from the time that you get infected to the time you have symptoms. There's another term that virologists talk about. It's called the latency period. And the latency period is the time from you get infected to the time you can spread that infection to other people. And it turns out that with this virus, that the incubation period can go out to 14 days. In other words, you can get infected and 14 days later, you'll start having symptoms. But the latency period is much shorter. And usually you are able to spread the virus at least 2 days before you start experiencing symptoms. So you have people walking around who are now infected, who can spread the virus, and they can spread a lot of it. And it turns out that just before the dawn, just before you develop symptoms is when you have the highest viral load. So you really can spread it very easily. And I guess another thing is that this virus, it's probably more political than the 2003 virus. We don't know how it got so political. And you may hear a little bit more about influenza later on, but influenza has the case fatality rate is much lower. It's about only 20% of what the COVID-19 case mortality rate is. So it kills a lot of people annually, but it's we have a lot of ways of dealing with it. And but in all of these pandemics, the people who are most susceptible are the elderly or people who have comorbid disorders. So can I have the next slide? So if you have really specific questions, I would like to direct you to the CDC website. That's cdc.gov coronavirus. And there are many, many answers to your questions there. And the next couple slides are going to be that I've taken from their website. But the first is talks about coronaviruses. So coronaviruses are a large family of viruses, and they cause illnesses in humans and in animals. And most of the time when they're in animals, they stay in animals. But occasionally there'll be a mutation that will cause them or allow them to jump from an animal to a human. And when that happens, then they can really spread. And in this case, if it's respiratory, they can jump. And in many of the coronaviruses, we know them as common colds. So there's at least 5 coronaviruses that circulate on an annual basis, and they just cause a cold-like symptom. But there are others, these others we've talked about, the SARS, the MERS, and of course, COVID-19. Next slide. And so these are transmitted by respiratory spread. And in most cases, the biggest viral load is in a respiratory droplet. And these droplets are greater than 5 microns in size. And when they talk or a person talks or coughs, then those droplets carry the virus. And And we'll talk a little bit more about later on about how far they're spread and the infectiousness of these droplets when I talk about masks. But they also can be spread by touch contamination, and that's probably not nearly as important though as respiratory spread in COVID-19. Next slide. And so what can you do? Well, you can, everyone knows the routine. You do social distancing. You avoid people who are obviously sick. You avoid touching your eyes, nose, and mouth because the virus can also enter your body through mucous membranes of the eyes, the nose, and of course, the mouth. And you should stay at home when you're sick because if by the time you're sick, you're really infectious. Learn to cover your cough or your sneeze with a tissue and then dispose of it properly, of course, washing or sanitizing your hands afterwards. And, but certainly the most important thing, in my opinion, is masks. And there are many physicians who would say that masks are as important as a potential vaccine. Next slide. So I'm going to talk a little bit about masks, and I'm going to give you the data. And so there's a number of publications now, scientific and medical publications that have come out that talk about the effectiveness of masks. And the next slide will show you kind of what are the major benefits of the mask. Well, number one, the mask can protect the wearer. And so early on, when you heard the scientists and the physicians talking about masks, they didn't mention that because they were worried that there would be a shortage of masks and that everyone would go out just to protect themselves. But in fact, that's a very important use of the mask. They also reduce the spread of the virus, of course, that are attached to these water droplets or in aerosols, and they can reduce the virus dose size. So instead of putting out a very large amount of virus, if you have COVID-19, then it would be a much smaller dose. And the smaller the dose, we now know that causes less severe symptoms if people get COVID-19. And so the next slide shows you kind of the prototypical mask that we've all heard about, the N95 respirator. And so I know many of you have been asking, why is it called N95? So I'm going to tell you. So it's called N95 because it filters out 95% of airborne particles that are 3 microns, or 0.3 microns, or 0.3 micrometers, if you like, or larger. And so these are tiny, tiny particles that it filters out. And so the droplets that you've heard about that carry the air, carry the virus, those droplets tend to be greater than 5 microns. And so what is left? Well, what's left are aerosols. And aerosols are very, very tiny droplets of air that carry viruses. And each aerosol has just a small number of viruses on it, typically. But these masks protect the users as well as the wearer, as well as other people. But the vented mask, you'll see some that have a little vent on them. Those aren't as effective in protecting other people as the non-vented masks. And so these masks, they may not completely protect you from illness, but in most cases, they would probably reduce the severity of the illness if you got it. Next slide. So there are other kinds of masks other than these N95 masks, and surgical masks and comparable cloth masks are at least 67% as effective as these N95s. And in some cases, if they're fitted properly, they may be up to 80% as effective. In fact, even a cotton t-shirt pulled over your face can block half of the inhaled aerosols and a lot of the exhaled aerosols. And some of you have seen people walking around with these thin polyester spandex neck gaiters. And so the warning about those is that very large droplets do not get through them. But what they do is they will take large droplets and they'll turn them into aerosols. And so the aerosols is a finer, and they will spread throughout a room. Now, what is it about aerosols then that are so important? Well, aerosols are less than 5 microns by definition. How small is 5 microns? Well, the finest dust that's in the air would be 5 microns or less. And of the dust in the air that you can't see, 90% will be 5 microns or less. And likewise, the aerosols that come from your breathing is about the same size. So this gives you an idea of why those masks are important. Can I have the next slide? So what about viral surfaces? We know that the virus can exist on surfaces. And on the right side of this slide, you can see that it'll stay on copper and metal for about 4 hours, on cardboard for 24 hours, so that pizza box, 24 hours, and stainless steel for 2 to 3 days. But how important are these? Well, what we know is that the half-life of those viruses is in fact about 6 hours. So even though we can detect virus, it's probably not a very high dose. And so unless you run your hand along like a guardrail or something and kind of scoop it up, you're probably not getting very much virus through contact. But still, if you touch something that has virus and then touch your eyes or your mouth, you can get infected. Next slide. So now I'm going to turn this back over to Heather.
Thanks, Russell. So just briefly, we get asked a lot about cold versus flu versus COVID. What does COVID look like? And Leslie, if you could put up the slide. Basically, I'm using this just to highlight a point. It can look like anything. It can look like the common cold. It can look like flu. It can look like asthma. There's a lot of crossover. As a matter of fact, I think the only thing that we have found that is specifically COVID-19 is lack of taste and loss of smell. So this is where it becomes so important to do morning screenings, to check your temperature, to talk to your doctor if there's any questions, because we can't just tell by looking at you, by examining you, whether this is a rhinovirus that causes the common cold or this is the flu. And this is where testing is going to come really handy, and Dr. Bierl is going to go into that.
Thank you. So I'd just like to take a few minutes to go over some of the different types of testing that people might be hearing about, particularly in the news, and where some of the confusion might come with over false negatives and false positives. So there's a lot of tests out there. There's a lot of even molecular tests. And when we think of molecular tests, this is how we diagnose COVID. And there's 2 different categories of molecular tests. You may have heard something referred to as a PCR type test. This stands for polymerase chain reaction. And then there is something called an antigen test, which tests for some of those particles that were nicely demonstrated on the pictures of the viral particle. So for the PCR tests and the antigen tests, there are rapid ones, there's slow ones, there's ones that you can get off of spit, off of a nasal swab that you'll self-swab, and then there's ones that a practitioner will take where they feel like it's actually scraping your brain, and that's deep in your nasopharynx. There's also some options out there where they'll pool testing, and then there's singular testing. And all of these have trade-offs. None of them is perfect. And the key is understanding the limitation for a given setting or population. So there's reasons why you might see one type of testing if you have a student in college, and another one if you're going into the hospital for a procedure. Next slide, please. So this is a general overview of how these tests play into the viral course. So the pink arch and the curve there is supposed to represent the virus's course as it runs through your body. And so the virus will begin with the inoculation at a very low level, and this is when you're exposed, and then over time it will replicate as it's designed to do and eventually reach a very high peak where you might be shedding a lot of virus, and then your body will take over and fight off the virus and drop it down to low levels again. And at that point, your body will start to react to it. And this is where we start to see antibodies. And the antibodies is your own body reacting to the virus present, and those become positive later in the course of disease. So on this slide, you see that the PCR, that type of molecular test, is often the first to pop positive, and then next would be the antigen testing, and then finally the antibody test. So even, previous slide, please. So even within PCR testing, there's a lot of variability in the tests that are out there. And there's a lot of different sample types that can be used. And at the end of the day, what we're looking for is how many viral particles can you get on that swab that makes it into a tube that will then be detected by the methodology being used. And so it becomes easier as you have more virus in your body to collect more virus on that swab. But you can imagine the day after you may have been exposed, you're going to have very little virus in your nose. And the place that you can get the most virus out is deep in the nasopharynx, the very uncomfortable brain swab. So if, for example, you thought you were exposed yesterday and tried to go in for a test, you might do a swab in an anterior part of your nose, but there's not going to be much there to detect, and not much of it is going to end up in our PCR tubes, and then we're not going to be able to amplify it, and it will be negative. And so this is one of the challenges with the different types of tests that are out there and the different types of collections are out there. It's all about how do we get as much virus there so that we can see it. Next slide. So this brings up the challenge with population screening, and that is that when are we testing in the course of this viral load? And so there's a very real possibility that if you're screening people that are asymptomatic, they're in that latency period that Dr. Kaufman mentioned. And so this might be a situation where they are not yet making enough virus that our test detects this. This doesn't mean that they're negative and that you're okay to go out and be mask-free. This means that you still could be shedding virus, and thus it should protect your breath. And so that is the constitute of the not detected yet. But in a few days, you could very well move into a category where you have a higher viral load and that you would be spreading it more quickly. And this brings up the challenge with screening, particularly in a population like a school where everybody is asymptomatic. We wouldn't want to have a false sense of confidence that a large number of people are not actually spreading disease. And so the idea is that we're taking a preventive approach, and the idea that we're just going to mask everybody and use precautions in case you might be in this early undetected phase. Next slide, please. So now onto antibody testing, because this is surfacing a lot, particularly in the news. There's a lot of different types of antibodies. We make them in response to a lot of different types of viruses. We may have made them in response to a previous coronavirus, and it targets different molecules on the virus. And there's, with this means there's a lot of different types of the tests out there. These tend to be a delayed reaction. They tend to be after you have cleared a lot of the viral particles. They also can go away. So depending on when you test, even if you have been exposed, you may test negative. If you test positive, right now we're pretty sure that that probably means you have evidence of past infection. However, what it doesn't mean is that you are immune. We don't know this yet. This research is still underway. Next slide, please. So the other thing I wanted to bring up is people have started asking questions about, well, there's a lot of virus out there. We have 8 million cases in the US. Are we close to something called herd immunity? So what is herd immunity? Herd immunity is the idea that if you look on the left, you have a red dot, and the question is how many of those red dots can spread to adjacent open circles. And so if the blue circles represent people that are healthy or vaccinated. And so if you encounter a healthy or vaccinated person who has immunity, then you don't spread it to them. And so what you see on the left is that each center red circle spread to several circles around it and multiply the number of people who actually had virus and had disease. And then on the right, what you're seeing is a setting where we have a high immunized population. And so there you see a lot of filled blue circles, and the red circles are unable to spread as much to neighboring open white circles because those folks are blocked by people that are vaccinated. And so it stops the spread to as many as people. Generally, we think it takes about 70% of the population to be either vaccinated or immune to prevent widespread of disease. So we have total confirmed population of confirmed cases of about 7.5 million to 8 million. This represents about 2% of the US population. Now, I realize we had a lot of trouble with getting a lot of people tested early on, but even the high ends of estimates place the undetected infection rate at most around 10 times this volume. So even at most, we're still talking 75 million people, which still only represents 23% of the population. And that's a high estimate, so it could be well under that. And so that means we're not really that close to 70%, and we need to still be vigilant about stopping the spread of the disease. So at this point, I'd like to turn it back to Dr. Kaufman. Thank you.
Thank you. And so I'm going to be talking at a pretty high level about treatment and vaccines, and that'll give us time to take a lot of your questions, and we can get into more details about vaccines if you like. But the next slide is another slide that I took from the CDC, and it summarizes the treatment. And like many viral illnesses, the care for patients is primarily supportive. That is, relieving symptoms, making sure people are well hydrated, and also managing the complications, managing respiratory problems. And as you know, many people have had to go on respirators and be intubated to maintain their breathing, but also other organ failure. Kidney failure has been another common feature of the severe form of COVID-19. And currently there are no specific antiviral treatments that are licensed for COVID-19. However, there are a number under investigation, and hopefully we'll be seeing those results soon. Now, many of you have heard about this drug remdesivir that was first approved over 10 years ago. For a different indication, but it's an antiviral. And it turns out that it has some effectiveness, but it's used in patients who are hospitalized and who are severely ill. And the data only show that it has value in shortening hospitalization and probably survival in people who are severely ill. In people who aren't particularly ill, there's no evidence that it shortens the time to be either viral-free or symptom-free. And currently there's no vaccine available, but there's a number of vaccines that are in the pipeline. And the next slide, I'm going to give you a pretty high-level overview of vaccines, and then we can talk about more detail later. So how do you make a vaccine? Well, typically in the early days, you would take, for example, with polio, you would take a polio virus, purify it, and then make it weak or even kill it. And then that whole virus became the vaccine. And now, as our technology has advanced, we figure out which part of the virus is particularly important to block the interaction with human cells. And then we tend to make a vaccine against that particular little function. And in this case, for COVID-19, it's against that little red spike that you can see on the surface of these viruses. And we do so by using recombinant DNA technology, by using very sophisticated technology. And in one case, we actually take the mRNA, that is the gene product from that would encode the spike, and put that into a vaccine and put that into patients. And in others, there are viruses that we open up, put a small piece of the coronavirus in it, and then infect people with those viruses. So as you can, this is pretty high tech stuff, but it's pretty exciting, in particular because it allows us to make vaccines that are more specific and probably have fewer side effects because we're only making them against a very tiny part of the virus. Now, why does it take so long? Well, it's complex, and it's complex, but it's in a very important way. is that you have to have a vaccine that's effective, and also that is a competent vaccine. That is, that vaccine will actually, in most people, will cause you to have immunity against that virus, and but also be safe. And so that's the balance that we have. And so why do we need to take so long? Well, you have to include many people in these trials to answer those questions. So when I was at the Wistar Institute, we created a vaccine against the rotavirus. Rotavirus causes gastroenteritis, and for many of you who have had children, your children have had the rotavirus vaccine that we developed at the Wistar Institute. When Merck did the clinical trial of that vaccine, they did 70,000 children. And after 70,000 children, the FDA said, why don't you do another 10 or 15,000 more? So it took 80,000 children to show that this vaccine didn't have complications from it. And so the current vaccines, the number of patients that are being enrolled in these trials is in the range of 30,000. So a lot of people, a lot of money. So will they work? Will they be safe? Those are the two big issues. And not only will they work, but will they work in a generalizable situation? When Dr. Lubell uses one of these vaccines in her clinic, we want that vaccine to be effective in all clinics, no matter where it is. And also, is it practicable? In other words, if you have to take this vaccine and you have to keep it frozen, and only in the last 15 minutes can you thaw it, well, you can imagine many parts of the world, you're not going to get that vaccine there. So it's not going to work very well. Also, how about 2 doses versus 1 dose? It's a big issue. You know, many people will get 1 dose. They'll say, that's enough, and not get the second. So when will these vaccines become available? Well, we know that many of the trials are approaching the end, and we're hoping to see results from those trials in November. And by the time the FDA has a chance to review all of these, and they'll probably eventually get an emergency use authorization, we think that these will be approved probably in January. It's conceivable that they could be approved in December. And but one of the things that we've done to shorten how long these vaccines take is that we've reduced the risk. So the way we used to do these vaccines is you would make a vaccine, you would test it in 250 people, and if everything worked, then you would make more and test it again, but you didn't put much money into it. Well, the government's put a lot of money in to reduce the risk, so that people, drug companies have started making vaccines before we ever completed the trial. So there'll be hundreds of millions of doses available whenever this is approved by the FDA. When can you get one? Probably there'll be a priority, and most of you will not be first order priority. The first order priority will be people on the front line, healthcare workers will probably be the first line. Second priority is probably going to be people in nursing homes and vulnerable populations and additional healthcare workers. And then finally, the big issue is, will everyone take one? Well, right now, the polls suggest that only 50% of Americans are going to take these. Now, Charlene's already told you, you need 70% to have herd immunity from these vaccines. So we're in a quandary here. If we don't get to 70%, we really won't get the full benefit of these vaccines. So that concludes my discussion of vaccines, and we can I can take specific questions about that later on.
All right, thank you, Charlene. Thank you, Russell. That concludes the SEC portion of tonight's program. So there is a box for Q&As if people have questions. I know a couple have popped up already. We have a question on commenting on how safe we consider air travel. Not really sure which of you want to answer that one. Dr. Kaufman, does that sound like something?
Well, I can. So my wife and I have traveled on the air, but you should know the background. And my wife and I both had COVID-19 in March, and we had like an influenza, moderate influenza, disease. But we feel that that we have what's called a COVID passport, which gives you some immunity, and we don't know how long that's going to last. But we're now being a lot more cautious. But on different airlines, for example, Southwest holds the center seat empty. And remember, the air in an airplane is heavily filtered. It's got these very fine filters, these HEPA filters, and so if everyone's wearing a mask, which the airlines do a really good job of enforcing that, if everyone wears a mask and you have the vent kind of blowing on you, that the air coming out of the vent is going to be very high quality. And so one of the principles is to make sure that you keep the air moving. And so we feel that, if you don't need to fly, you shouldn't. But for our own family, we've told them that if you have to fly, if you use precautions, we feel that it's reasonably safe. There have not been that many people who have been infected on airplanes.
Okay, a bunch of questions popping up here about vaccines. One here basically says lots of speculation about eventual real-world effectiveness, especially the ones likely to be approved first because they may not be 100% effective or nearly so. How should individual Americans interpret the point estimate of a vaccine's disease reduction for themselves and their individual risk? Any insights or predictions as to how the CDC and other players will manage expectations with the general population? And I guess there's some concern about vaccine hesitancy and confusion regarding the weaker effectiveness.
Well, let's go to slide 29, if we can. So this term vaccine effectiveness relates to the ability of vaccines to prevent outcomes in real world. So it's a real world setting. And so you have to know that not only does this vaccine work in a highly controlled situation, but also does it work in primary care settings? Does it work when you have less stringent eligibility than you would in a clinical trial? Does it work when you assess the other health outcomes? Once do you have enough experience to really pick up not only the adverse events that we would expect, but also adverse events that we wouldn't expect. And those would be called non-solicited adverse events. And so the way you do these trials is you have a bunch of questions that you ask the people who are getting the vaccine, but you also have them give you a narrative in terms of, so you find out other things that might cause problems. And so not only do you have the vaccine and the trial, but after the vaccine is approved, there is then ongoing monitoring and collecting data about these vaccines. So we continue to get more and more information about vaccines. And so, so the question is, do you want to take it right up front? Well, there may be adverse events that, that we will find later that, that become important. However, I believe that with the vaccines that we're developing now, they are so specific, and most of them are just focused on that little spike of the virus, that I think it's much less likely that we're going to see adverse events from in a specific way. On the other hand, vaccines fire up your immune system. And if you fire up your immune system, many times you'll fire it up in a very broad way. And so you can have broad effects from these vaccines. Well, one of the things that we know is now that I've just finished reviewing the early data on the 6 major clinical trials, and almost everyone who has gotten these vaccines has a little fever, maybe some muscle pain, some even have chills, and so we think that there may be some people who will say after the first dose, they're concerned that maybe they actually got the virus, and they don't want to take a second dose. So those are just considerations about these particular vaccines. But I believe that we will know which of these vaccines produces an immune response. The real world knowledge, it'll take a while to get all that.
Great, thank you. Couple more questions here that have been popping up. This person is questioning acquired immunity from having had COVID and recovering from that. If we could address that a little bit.
Well, so what we know is now that there a lot of people have had COVID, and we've monitored their immune system afterwards. And what we know is that by about 3 months, the people who have had very mild cases of COVID, some of them have undetectable antibody levels against that's specific for the COVID, this particular virus. And but we also know that people who have a moderate amount of disease, moderate symptoms to severe symptoms, that those people tend to have longer lasting antibody production, but they also have a cell mediated, that is a T cell response, and these T cell responses last much, much longer. And so we think that those of us who are optimists believe that, that there may be long-lived immunity. So what's the basis for that optimism? If you look at the 2003 SARS virus, people who got that virus, now remember they were almost all of them were very sick, but many of those people this many years later, 17 years later, still have immunity against that virus.
Great, thank you. Question for, again, either of you. What's your suggestion of social distancing with masks indoors?
Charlene, you want to take this?
Sure. I mean, the evidence that social distance masks indoors can be okay is that in the hospitals, we have seen that as a reduction in in-hospital spread. And so that gives me a lot of confidence in the program that the school has put together, where they combine the indoors with masks and social distancing. Where we see some problems is where people start to take off their masks in lunchroom settings or or outside of that setting, and they drop their precautions. And then we start to see some transmission issues.
Thank you. All right, talking about the flu vaccine, Dr. Kaufman, this seems like it might be up your alley. How important is taking the general flu vaccine this year, and when would you suggest it get administered?
Yesterday, you should have gotten it administered. All of us should get it administered, and people who study flu feel that the biggest impact you can have on flu is to give children the flu vaccine, and because children are super spreaders of influenza, and older people, when given influenza vaccines, they don't respond very well in terms of developing immunity. So probably only half or a little bit more than that of older people who get influenza vaccines actually develop a significant strong immunity against influenza, but they may develop some immunity. So some is better than none. And so we believe that you should get it right away. Everyone should get the influenza vaccine this year. And that may reduce pretty dramatically the amount of influenza. We're hoping that with a combination of influenza vaccine and masks and social distancing, that actually the amount of flu may be much lower this year.
Great, thank you. A question about the holidays coming up, which I definitely think is on everybody's mind. What do you feel about family gatherings for the upcoming holidays? Charlene, do you want to take that one?
Sure, it's certainly coming up in my household,
Yeah.
and we still are hesitant about what to do about this, particularly when you're talking about elders. And so balancing the social, how how socially distant you've been, how precautions you've taken, and the risk of a community gathering inside a house where people are likely to decrease their masks. And you're likely to have variable backgrounds of people who have been taking the social distancing and masking seriously, which makes it hard, particularly if you scale up to a large family gathering that's coming from lots of different locations.
And also, this is another opportunity to eliminate the people who cause trouble at your Thanksgiving dinner.
Best answer of the night. Moving on to restaurants. How do you guys feel about outdoor seating at restaurants is one of the questions that I have. And actually, while we're on that, I can even elaborate and say, how do you feel about indoor restaurants as well?
Well, my opinion is that outdoor, you're probably pretty safe if you have social distancing at the same time, and you're better off on a breezy day than on a day where you're kind of stuck in a corner and you're not getting much active ventilation. On the other hand, indoor, I'm still pretty reluctant, and I know unless there are fans moving the air around, and so, that's a double-edged sword. If they're moving the air around, they could blow the virus toward you, but they're also diffusing it in a way so that if you got it, you would get a lower dose. So
I'd like to, yeah, no, I would tend to agree. And the thing that I would add is how often. I mean, so the number of contacts is important because you might get a small dose in one setting and then another small dose the next night, and those things can be cumulative. Yeah. And so is this one special occasion where you're going out for once in a month, or is it something you want to do every night? And I think that does make a big difference as well. Personally, we're not going even to outdoor restaurants yet because we're concerned about the distancing. We'll do takeout and sit outside at home. And so it's one of my favorite things to do, so it really is paining to me.
So my wife and I have some personal experience with this. My birthday was March 7th, and so she rewarded me by taking me to the Capitol Grill. And we had to wait for 20 minutes in the waiting area where there were many people drinking and carrying on. And it was after that, following the appropriate incubation period, that we were cases number 100 and 101 in Philadelphia. This was before anyone was wearing masks. So I'm pretty certain that I got infected at indoor at dining.
Sure. Another question actually about vaccines. I'm not quite sure I'm following the whole question, but worrying about accuracy of test results, worrying about patients who perhaps died with COVID but of other causes, but being included in death statistics. And then a personal question that he's asking of us, do any of us have any anxiety about receiving the vaccine themselves? I will personally say I will be happy as long as I feel like this is a safe vaccine and it's been vetted. I will absolutely get this vaccine. I actually put in to begin the trials. Unfortunately, didn't get picked. Would have loved to be picked. But anyway, in terms of talking more about the vaccines, I don't know if that's something you could speak to, Dr. Kaufman.
Yeah. So, I mean, I think this issue about, let's start off with the people dying of coronavirus or of COVID-19, and there's this. I think it's a false narrative that doctors say that patients die of COVID-19 when they had some other condition. But, physicians who do this, this is a serious thing, and we take this seriously. And I mean, I've signed many death certificates, and this is a very important thing. So there'd be very few doctors that would say someone died of COVID-19 when they actually were having just a heart attack. So and they happen to have COVID-19. So that's the first thing. Now, and Heather, what was the second question then?
That was basically the death statistics and accuracy of test results.
Yeah. So Charlene, I mean, I think you can handle that.
Right. So in terms of the accuracy of the test, when they're doing testing in hospitals, they're often doing the PCR testing, and those are very highly accurate at this point. There are very few false positives with those particular tests, particularly given the number of cases that we are seeing in the population. We started to talk about some false positives when it comes to the antigen tests, but those aren't usually the tests administered in this type of setting that you're talking about. The other place that we will see false positives is with the antibody tests, because sometimes the body reacts to a previous coronavirus, and depending on which antibody we're testing and which test manufacturer we're running, we could see some cross-reactivity with other coronaviruses. So that's where we see false positives. And then we see false negatives in the PCRs.
Great, thank you. Another question from a parent. If there are cold or flu symptoms in our kids, how quickly should we see our pediatrician, and how quickly should we go for a COVID test?
No, Heather, that's yours.
And then the second piece of that, if we're cleared, how much time till we retest? So basically, we're following a nice logarithm in my practice as well as at school, depending on the type of symptoms. So if you just have a runny nose, if you just have a sore throat, we may watch you for a couple of days before making any decisions. However, the more symptoms you have, the more likely we're going to be to get you tested. Call your pediatrician. They will see you in the office. We are seeing patients day 1, 2, 3 of these symptoms. We're trying not to test people too soon, again, for the reasons that Charlene was mentioning. So we will send you out. We will do rapid tests in the office depending on what we think is appropriate. In terms of being not concerned or cleared, so depending on what we find, if we think you have allergy, strep throat, if you're flu positive, we may treat you differently than if you have an exposure for COVID and send you to get tested. If we think if you are positive, we're going to give you 10 days plus symptom free before we're going to clear you to go back to school. So there's a lot of different parameters that we're going to follow depending on the exact situation, and your general pediatrician is going to be able to help walk you through that. Did you guys have anything else? No. Charlene, how accurate are these self-administered nose swabs that are now offered at Rite Aid and other sites?
They have some challenges because of the collection type and the ability to get the virus on the swab. And so they're going to be less sensitive than some of the deeper tests or the hospital administered tests. The other challenge is that if you're testing an asymptomatic patient, then there is usually less of a viral load to pick up on that swab as well. And so you should not, while they're good to get in the sense of watching your own health sometimes, I would not say that you are, that a negative test from Rite Aid or CVS means that you have zero chance of transmission. It is not that highly sensitive.
Yeah, as someone who's actually having to do the tests on patients, it's not necessarily easy to get a good sample, even when I'm the one doing it on a patient. So if you are trying to do it yourself, I would imagine it's pretty tough to get an accurate specimen. We have a question about what are our thoughts on hotel stays? I've actually had to stay in a hotel during this, and happy to quickly address it. I had no choice. I called ahead to see what precautions they were taking, made sure that the room was empty for the day before. The particular chain that I stayed in had taken all the touch points out of the room. There was no comforter, there were no magazines. They had sterilized the remote. There were no glassware. So I did feel pretty comfortable. You were masked anywhere in the hotel other than your room. But I don't know if Russell, if that's something that you wanted to touch on.
No, I think, when you think about the ways you would get it, contact, and I think they've optimized, Heather, sounds like at least the hotel you stayed in, they optimized that. Ventilation, the hotels aren't going to have HEPA filters. So, you can imagine that in their air conditioning system, there could be virus, but it's probably low concentration of virus, and and then the third would be interacting with with staff, and you'd certainly want everyone to be wearing masks.
Exactly. Another question about vaccines. So if we have an at-risk family member who had a reaction to the Pneumovax vaccine, would that make them more likely to react to the COVID-19 vaccine and therefore influence decision-making regarding which available vaccine should be pursued?
I don't think there's any evidence that would suggest that just because you had a reaction to a Pneumovax that you would more likely have a reaction to a different vaccine. I don't know of any evidence of that.
Thoughts on indoor masked play dates with SCH classmates? How about sleepovers? We keep saying no to both our kids, but would appreciate an expert opinion. Charlene, do you want to touch on that, or?
Well, it would be hard to keep masks on during a sleepover. And so I would have concerns about prolonged restlessness and exposure in a closed space, certainly for a sleepover. In terms of play dates, I think it depends on how the kids are playing. I mean, our kids are in school and keeping socially distant and wearing masks, and I feel comfortable with that. And so if you're setting up a play date in a similar type setting, I mean, I suppose that would be fine. I mean, my son is a 7th grader and tends to do more video games, and so that's easily done remotely, but we do occasionally have him gather with another friend, masked but distant.
I'll add, in our lower school, we're cohorting. So, you know, if you have that masked play date with someone who's already in your cohort, probably the safer option than crossing cohorts. I agree, mask, distance. I'm telling people if they really do need to move indoors, try to open windows as well. I know moving into the winter, this is going to be tough, but the ventilation piece as well. Okay. This is definitely a question that's on my mind. Should college students coming home for the holidays be tested before coming home? Charlene?
Well, how long are they going to quarantine before their test?
Good question.
So it brings up a point that a test, even at Rite Aid, is great if you've been in isolation for 7 days. Yeah. Then I think you can have a fair amount of confidence that your test, even at a Rite Aid or CVS, is negative. But if your college student went to a party the night before and tests negative the next day, I would not have a lot of confidence in that negative test and might encourage some distancing even within the house. And maybe it's the time that they catch up on some sleep in their room and have a tray delivered for a few days. Mm-hmm. That's my thoughts. If either of you want to chime in, having college, older kids.
You know, we've been talking about this quite a lot, and our plan when ours comes home is to do exactly that. Have him really sort of quarantine himself for about 7 days and then test him. Whether he quarantines there in his apartment or here, we're not yet sure. Russell, did you have any thoughts on that or no? Another question here, and I'm not quite sure, this person might want to actually, how do you anticipate that the vaccine will be administered?
Yeah, most of these that are in development right now will be administered by an injection. And there's some variation in the injection methods. There's one oral vaccine being developed, and it's later. It's in later stages. Or earlier stages. No. So, but at this point, you know, it'll be by injection. And one of the kind of the difficult things about this is all the vaccines that are currently that will be used for injection, they have to be kept frozen, you know, before they're given, and so they have to be pretty close to a freezer. And you know, within a couple hours of coming from a freezer, so so that's an issue as well.
I would say, going on to that, there's an addendum to that vaccine question. Will there be community-wide vaccine administration sites, schools, or private practices and clinics? I'm not sure that we know the answer to that yet. I don't know if you have any inkling of what that might look like, Dr. Kaufman.
Well, Heather, you probably know a little bit more through experience than the rest of us, but there's been this pediatric network for vaccines that's gone on for a long time. I know Paul Offit's been involved in all of that. But during the H1N1 pandemic, a similar network was set up for adults, and then it was allowed to, basically disintegrate. So there is no such network for adults. But on the other hand, public health departments, hospitals, medical centers, all will, are working right now to develop plans around all this. I'm still a faculty member at Duke, and I know that they have some pretty detailed plans for how they're going to administer these vaccines.
Right. In terms of the question about schools, as a pediatrician, we've been asked certainly to sign up for the registries so that we will be able to give the vaccine when it's out. I think that the kids are probably going to be among the last to get it just because of the risk factors. So if and when it becomes available, if and when it becomes an option to give it at school or community sites, certainly that would be something, that we would make people aware of. I think I'm gonna take this one last question, and then maybe we'll start wrapping this up. Question about lunch, since it was brought up a little bit earlier. What's the risk of transmission during lunch? Since masks are not being worn, what's the school doing to minimize risks? Are open windows, fans? What other protocols are being used? I could touch base on that one if you'd like me to.
That sounds like a good one for you.
Okay. So, depending on the section, we are either having them eat in their classrooms, in lunchrooms, in the gym, in outdoor tents. So there's a lot of places we have people set up to eat lunches. The tables are set 6 feet apart. In some of the rooms, everybody is facing in one direction. We are encouraging quiet lunches as much as possible and fairly quick lunches. We have great ventilation in all the rooms. There's way fewer people in the rooms than they are set up for. So we feel pretty confident that it's a safe scenario. And again, we're trying to keep them as short and as quiet as possible. I think that covers one more came just down. Let me see. I'm going to have this one last one for you, Russell, and then we will ask anybody else who has questions to please hold them and feel free to send them to Leslie or Melissa in the development office, and they can pass them on to us, and we can certainly get back with any individual questions. So the last question was, the biggest concern sounds like it's about how aggressive transmission is. But given that this is less severe than SARS-1, is it accurate to assume that if you test positive and have no comorbidities, that it's relatively safe and will self-resolve even after feeling a few days uncomfortable?
Yeah, I think that's probably
are you about long-lasting disease?
That's probably not a good way to think about this virus. That there are many people who appear completely healthy. They're young and they have devastating effects. I'm going to just give you just one example, and in this case, the exception really proves the rule. I was talking to a friend a week ago, and his son just finished a 9-year PhD program at Carnegie Mellon, and this was at the end in December, and he was going to be off on his career, and he developed COVID-19, and he developed a severe respiratory component to it. Was hospitalized but not intubated. Was in the hospital for over 2 weeks, and but has had profound fatigue, and now he's out. But he had it in March, and so he's out 6 months, unable to work, unable to exercise, has severe lung damage. So this was a healthy young guy who would jog all the time, worked out all the time, had no known comorbidities, and yet he's had a devastating illness. That's just one case.
Thank you. So I hope you had a lot of your questions answered. I hope you learned a lot tonight. I know I actually certainly did. I enjoyed listening to both of you. Mandy, do you want to wrap this up?
Thank you, Heather. I just want to let you folks know that we did record the presentation and also the Q&A session. And as Heather had mentioned previously, if you have further questions, just forward them to either Melissa Brown or Leslie Newbold at the Development Office. And I want to thank our presenters. You guys were fantastic. We really appreciate the information. You did a great job tonight. Thank you. Have a great evening, everyone. We appreciate you participating. Bye-bye.